and myopia. Professor Hema leads the Physiological Optics Research Laboratory at the university with a particular research focus on accommodation and myopia. She has authored more than 70 peer-reviewed publications in leading ophthalmic journals. In recognition of scientific contribution to optometric research, she was awarded the Neil Charman Medal for Research Excellence by College of Optometrists in 2015. Please join me in giving a warm virtual welcome to Professor Hema. Over to you, ma'am.
Thank you, Shamla. I'll just share my slides. And while
Okay.
can everybody see the slides?
Screen is visible.
Okay. So today's talk is going to be on myopia development, progression, and management. I'm going to talk to you something around the development and progression for about half of the talk or slightly more, and the rest is going to be on myopia management today. Okay, so myopia has been a problem for a very long time, but this article in 2008 in Nature actually started bringing the research community, showing how big a problem this was becoming at that time. It's, of course, a much bigger problem now. In 2016, the World Health Organization report was published with the prediction that 50% of the world's population will be myopic by 2050. So that kind of showed the world that this was effectively a pandemic in some ways that is engulfing everywhere in the world. Some countries were getting there much faster than others. And as such, myopia isn't a problem, really, isn't it? Because more people who need glasses keeps more optometrists in jobs. So why should we be worried about myopia? The reason really is the prevalence of high myopia. So here in this figure on the left, you can see the proportion of high myopes when the level of myopia is shown in the light blue bars and the high myopia is shown in the smaller dark blue bars there. And if the world's population had 22.9% myopia, high myopia was 2.7% of the world's population. Okay. But if number of people per million who had myopia went to about 50% in 2050, then close to 10% of the world's population will have high myopia. And as optometrists, we all know the issues that high myopia brings and the chances of irreversible vision loss caused by myopic maculopathy and other myopia-related pathologies. So the reason that we are actually concerned about this myopia prevalence and why we would not like to see this level of myopia prevalence is that high myopic category there. And if we were to lose 10% of the world's population to vision loss due to myopia, that is a huge loss to economic productivity, etc., across the world. So it is something which is very, very important, not just with a cosmetic appearance kind of perspective, but also in longer term economic forecasts around the world. Now, although the prediction was that myopia prevalence would reach 50% by 2050, the prevalence is already becoming high. It has reached 45 to 50% in some urban settings within Europe. It's been way more than 50% in Asian countries, particularly China, Singapore, Taiwan. And this figure here shows the data from 2020 of adult myopia. This isn't children, this is adults. And if you see there, India, adults having myopia is already at about 27%, which is quite high in global terms. And when it goes to children, it becomes even higher with the changes in lifestyle, etc., that have come about now. And these tables here show the prevalence of myopia in Europe, in teenage children, and in Asian children, particularly from Hong Kong, Japan, China, South Korea, and Singapore. And as you can see, the prevalence of myopia in these Chinese populations is anywhere between 80 to 96%. And the prevalence of myopia in Europe is ranging from somewhere like 3% in rural areas to 42% in the more urbanized regions. So we're probably going to reach that 50% target way before 2050 from all current predictions. The previous estimates in 2016 were definitely on the low side. So what causes myopia development? Uh, there, there is a strong genetic component with myopia, but environmental factors are becoming more and more important. So with genetics, we know that parental myopia plays a very important role. And somebody who has one myopic parent has 3 times a higher chance of being myopic themselves than somebody who has no myopic parents. And if they have 2 myopic parents, their chance of becoming myopic increases 6-fold. Now, ethnicity also seems to have a big impact on people becoming myopic. East Asian children tend to be 8 times more likely to be myopic than Caucasians. Indian children are not too dissimilar to Caucasian children in the impact of developing myopia, but as you can see, even in Caucasians, the prevalence of myopia is really increasing now. So it couldn't just be this ethnicity and parental myopia, which are increasing the level of myopia in the population now. So given this, let's think about what environmental factors could these be that are triggering this level of myopia. Now, before I proceed, am I going too fast? Do you want me to slow down or something? Okay, I'm assuming I'm okay. I'll carry on. So environmental factors, the key things that have come out
It's just trying to unmute.
Sorry?
No, you are absolutely fine, Hema.
Okay, thanks, Saranya. Really appreciate that. It's always odd talking to a screen in front of you when you can't see any people.
I know. I know. Yeah, thank you.
Yeah. Anyway, so the key environmental factors that we've been thinking about are time spent doing near work, educational attainment, outdoor activity, and effects of light. So I'll go through these one by one and what might be causing these to have an impact. Now, time spent during near work, we all have to accommodate to do near work, both adults and children. And when we look at accommodation in myopes and emmetropes, particularly in children, all the data has always shown that myopic accommodation tends to be slightly lower for a given stimulus than emmetropic, although some studies have shown much larger variability, and myopes sometimes come close to what emmetropes accommodate. But consistently, onset of myopia has been shown to be associated with changes in accommodation response. So accommodation, I'm sure you're all used to measuring that in the clinic with the push-up test, measuring the amplitude of accommodation. But what we're talking about here is not the amplitude of accommodation where we do the push-up. Instead, it's how much do they actually accommodate when you show a target at, say, 20 centimeter when you do the push-up test in a myope. The emmetrope might accommodate by a good 5 diopters or so, but a myope will accommodate only by around 3.5 to 4 diopters. So although they can see that clearly, they're not accommodating as much. That's what I mean by lower accommodation response. And the other thing that's shown is accommodative facility that I'll come to later. So this is from our own study where we looked at accommodative response to different spatial frequencies, but this is for the letter chart, the optotype. And when we give somebody a target placed at 25 centimeter, to say, which will be 4 diopters, this shows how much they accommodate. And emmetropic response was roughly for a 4 diopter target, somewhere around 3.5 diopters. So we all have a lag of accommodation. Our eyes are lazy. We'll never accommodate fully. We'll have a little bit of a lag where the eye decides this will do. This is clear enough. Okay. Now, here is the data for emmetropes on the left, and on the right here is the data for myopes. And as you can see, the emmetropes all accommodated fairly well and consistently for each target, but myopes varied a lot. Some myopes accommodated extremely well. They went to the same level as the emmetropes on the other side and accommodated close to 3.5 diopters, but some would only accommodate by a diopter for a 4 diopter target. Now, as you'll see, I've changed slightly where the stimulus is because the spectacles that the patients were wearing will also have an effect of minification, magnification. So I've corrected for that here. So overall, what we know is myopes can vary quite a lot in how much they accommodate, and that has an impact. So if you don't accommodate enough to see something, your eye is used to seeing that blurred image. Okay. And that blur can tell the brain that my vision isn't clear. You have to grow longer to correct this, and the eye might start growing because of this. So this has been the most established mechanism why people think myopes keep progressing to become more and more myopic once they get into myopia. Okay. And the reason that they don't accommodate as much, again, is linked to sensitivity to defocus. Only if your brain recognizes something as being blurred, we're going to try and accommodate. But myopes often have been shown not to be as sensitive to defocus blur as emmetropes. Okay. Now, the sensitivity to blur is important both for accommodation and to say, even if you do a +1 blur test during your clinical time, you will see that although myopes won't reduce their vision by more than 3 lines with a +1, but emmetropes, if you put the +1 blur, they will reduce by 4 lines. So those differences also can be seen in a clinical setting as a result of this reduced blur sensitivity. They're not accommodating at all with the +1 blur test, but they still show that reduced sensitivity. Okay. So the hyperopic defocus at the eye caused by this lag of accommodation being higher in myopes could be causing axial elongation of myopia. But the other thing that we see is that their accommodative facility is also reduced. They are slower in accommodating. So facility measures, that's a flipper test that you do, where you give the patient a target and then you will flip the lenses to + and -2 and see what they can read. So in our study, we did a dynamic measurement of accommodation throughout this flipper test. And what we found was even if the myopes accommodated, their accommodation was lower than emmetropes, but they were far slower in disaccommodating. Okay, so once they've accommodated, going back to zero took them longer again. And that in itself, that dynamics could have an impact on how they progress, becoming more and more myopic. Okay. Moving on to binocular vision. We know that binocular vision has an impact on myopia development and progression. But there are all these papers that you might have seen around esotropia and myopia and how some corrections really help patients who have esotropia. But what we know for sure is those who have a high ACA ratio, which is AC is accommodative convergence, A is accommodation. So when they accommodate by, say, 4 diopters, their accommodative convergence will be quite high compared to somebody who has low AC ratio wouldn't converge as much for 4 diopters of accommodation. So that's the ACA ratio. If they converge a lot for every diopter of accommodation, then their chances of progressing are much higher than those who don't. So all these put together have a big impact on how near work will cause increase in myopia progression. And we know that myopia is higher in urban areas when compared to rural areas. So the question here that I wanted to pose was, could accommodation really be linked to myopia progression? So urban areas tend to have a lot more educational kind of settings. People often move to an urban area to get access to better schools, to better facilities for kids to learn, right? And when there are those facilities for spending more time on near work, and in rural area, kids tend to go and uh, be around farms or do task in much more open, white space regions where they can see much further distance. In those regions, the myopia prevalence is much lower and their accommodation demand is also much lower. And therefore, that kind of indicates that accommodation could be linked to myopia progression. And it's been shown that even though this is not early onset myopia, university students, when they are doing a lot of hard work, often progress into myopia or progress faster with their myopia during their time at university. Now, there are a couple of studies which look at different occupations and near work demands. Famously, one of the studies used microscopists, okay, who were looking through a microscope at samples. A microscope usually corrects for your refractive error. They don't necessarily have to accommodate, but our eyes still accommodate because of the proximity of the target. So there's proximal accommodation. And microscopists, after they started their job doing microscopy, often became myopic. So more near work demands definitely led to more myopia, but microscopy is just one example. There are other occupations as well which have been studied. Okay. Children who read more have also been shown to become more myopic in the past. Now, in the past, at least only reading used to be near work. But now we see a lot of children on their phones. So they're doing a lot more near work than people used to in the past. And that in itself poses another kind of challenge that, when people were just reading, nobody really read for that long. But a child can now spend a phenomenal amount of time in doing near work just by browsing, etc., on their phone. Okay. Now, in general, there has been no studies which show phones are worse than books or anything in terms of developing myopia. So use of devices per se is not essentially the problem, but the problem is the amount of time that we spend looking at near. So this is the classic picture from a 2008 paper from Sydney Myopia study, where they had a big cohort of children assessed in schools. And they took the data for how much time people spend doing near work and outdoor activity. Okay. And the data showed that those who do a high amount of near work, which is shown by this blue arrow here, tended to have a much uh, lower, a much higher chance of getting myopia. So this yellow arrow here shows that high amount of near work and low amount of outdoor activity. Okay. And the blue arrow shows somebody who does high amount of outdoor activity and a high amount of near work as well. So that's something which people haven't explored much before. That is the group which actually had the lowest odds of becoming myopic. It's not about spending all your time outdoors or all your time indoors. So these people who spent a high amount of time doing outdoor work and low amount of time during near work, the dashed blue arrow, actually fared worse than somebody who did that high amount of near work and a high amount of outdoor activity. So the eye needs variety. That's what I get from this. You don't want the eye to just have outdoor viewing experience. You do want the eye to get some near work experience, but it has to be balanced. One is not necessarily better than the other, but a good balance between outdoor activity and near work has always been very helpful in controlling the development of myopia. Okay. Now, outdoor activity, why should it control myopia development or progression? Number one, we've talked about accommodation before. And if you do more outdoor activity, accommodation is relaxed, right? But also, daylight exposure increases retinal dopamine levels, and that in itself could help with reducing the chances of getting myopia because dopamine acts as a preventative for myopia development at retinal level, and GABA leads to increase in myopia. So these chemicals also act at a retinal level. Vitamin D has also been suggested to be linked to myopia development, although there is no evidence that giving it vitamin D supplements in any way will increase the chances of myopia prevention. So please don't suggest vitamin D supplements to any of your patients. That really does not help according to the evidence. But daylight exposure related vitamin D has been found to have some correlation with reduction in myopia. Okay. Also, when we're reading at near, we're only focusing in our central vision for that clear acuity in around the macular area for reading, for looking at small devices or books in our hand. But when we're looking outdoors, looking at vast spaces, our peripheral retina gets simulated as well. And we need to remember that the periphery has a lot more neurons than just the center. So that brings me on to the theory about peripheral refraction and myopia. And if we look at a normal eye, which is shown by this figure on the right, you will see that in a normal eye, emmetropic eye, you will find that the refraction is pretty much zero in the center, but the prescription when we go out to the periphery is also going to be very, very similar because the eye will be more spherical in shape in an emmetropic eye. But as the eye grows longer in a myopic eye, there isn't a global expansion in the shape of the eye. The eye is being stretched. And that stretch makes the eye into a more ellipsoid shape rather than that spherical becoming bigger, which is seen by the image on the right there, the myopic eye. So although the center is myopic and we correct that with minus spectacles, the periphery does tend to go slightly hyperopic. So what would the minus lenses do to the periphery in front of the eye? They would actually make that peripheral prescription even worse. It's going to become even more hyperopic and the vision goes down. Now, the proof for this comes from various studies on peripheral refraction. And this figure is from one of my studies from 2010, where we measured myopes, emmetropes, and hyperopes. Hyperopes are shown by the blue lines there. So we zeroed everybody's prescription for center. So whatever we measured at different eccentricities, we subtracted the central measurement from that. So what we're measuring is relative peripheral refraction. Okay, so relative to the center, if we were to correct somebody for their central prescription, what will they be left with as a prescription for the peripheral regions? And that for the blue is predominantly actually on the minus side. They're going to be left more myopic, which is the hyperopes tend to have a more myopic peripheral refraction. Emmetropes are shown by green, and they do have more or less even, only when it goes out to 60 degrees in the periphery, they are going into a more hyperopic region of prescription. But the red ones here are the myopes. And as you can see here, right from about 20 degrees onwards, their prescription starts becoming quite a lot hyperopic in the periphery. And the neurons that are serving the periphery are around 50% of the neurons in the eye. Yes, macula has a huge concentration of how many nerve fibers serve the macula, but the rest of the retina also plays a part in eye growth and signaling whether the eye is myopic or hyperopic. And we feel if the peripheral retina is to send a signal of whether the eye is shorter or longer, this peripheral refraction will actually fool the brain to thinking that the eye is not long enough. So grow and correct this spherical refractive error. So that's why our spectacle corrections for the center are not enough for the periphery as well. And this is the basis of a lot of the myopia control mechanisms that I'm going to talk about later on. Okay. So the difference in peripheral refraction between refractive groups remains consistent even when somebody accommodates. Okay, so you might think as soon as somebody starts accommodating, all this will disappear, but no, it makes no difference whether you accommodate or not accommodate. Whatever that peripheral refraction difference is remains very similar. And also when we turn our eyes to look to the right or left, it makes no difference. That peripheral refraction remains fairly constant. So we've tested it in every possible way to see, will it change? So whatever myopia control treatment we give for the peripheral refraction will hold even during near work or when they're moving their eyes. Okay. So overall, myopia development and progression is a complex interaction between both genetics, environmental factors, and also clinical and visual characteristics of the patient, such as the ACA ratio. Juvenile onset myopia usually happens between the age of 18 and 13, between the ages of 8 and 13 years of period when they are early in school years, and they tend to have a much faster progression. At that age, the eye tends to be more elastic, the whole body is growing, and as a result, the eye can grow really fast within a short span of time. And they do grow very quickly, but they do stabilize. Around the age of about 21, it completely stops. By 18, it slows down considerably. Okay. Adult onset myopia is very common in some populations, particularly university students and occupational instances that we discussed earlier. Okay. So why then correct myopia? with myopia control rather than just correcting it with single vision spectacles and leaving that. Because, of course, if you look at the previous one, you know myopia is going to stabilize by the age of 21 years. They're not going to progress anymore, right? The reason that we want to go for myopia control is that every single diopter increase in myopia has a significant impact on somebody's risk of things like retinal detachment, risk of open angle glaucoma due to high myopia, risk of cataracts or myopic macular degeneration. So before, we used to see this graph on the left where up to 6 diopters, the risk didn't quite increase. They were fine. If you have up to 6 diopters, you'll be absolutely fine. Only when the myopia is higher than 6 diopters, all the risks of myopic maculopathy, etc., will increase. So we wanted patients to be under 6 diopters of myopia. And that's what I remember reading when I was an optometry student. But this paper from Bullimore and Brennan plotted the same graph on the left on a logarithmic scale, okay? And when you plot this on a logarithmic scale, you see clearly that with every diopter of increase in myopia, the increase in the probability of developing myopic maculopathy in this case, but also retinal detachment and so on, increases on a logarithmic scale. So definitely somebody who has 3 diopters of myopia will have a much lower chance of developing myopic maculopathy compared to somebody who has 4 diopters of myopia. And that logarithmic decrease is going to be worth the years of myopia control that the patient is trying. Okay? So that's the logic for why we want to use myopia control on patients who are progressing. Okay. And with that in mind, we'll move on to myopia management. Okay. Myopia management can be done through various interventions. The first and foremost is lifestyle interventions, which is optimizing the environmental stimuli that the patient is getting to become myopic. So if we reduce these stimuli for myopia, they're less likely to develop and progress to becoming more and more myopic. Second is optical devices, either through spectacles, contact lenses, specially designed for myopia control, or orthokeratology. Third is pharmacological intervention, which is using atropine. And the third is new devices such as fourth is the new devices such as red light therapy, which have become more popular in some parts of the world recently. So let's start with the first one here, the lifestyle interventions. Lifestyle interventions work absolutely brilliantly for the pre-myopes, those who are not myopic yet. You can prevent them from becoming myopic through lifestyle interventions. These become far less effective once somebody is myopic. But if you find a pre-myope, that is somebody who has family history of myopia, which is one or more parents have myopia, they have less than 0.75 diopters of hyperopia at age 6. Okay, that's not 0.75 diopters myopia. Remember, we're all born with about 2 diopters of hyperopia as babies, and the eyes have to grow to reduce that level of hyperopia. And by age 6, the level of hyperopia in our eyes should be around 0.75 diopters. If it's less than this level of hyperopia, then they are at risk of developing myopia or are known as pre-myopes. If they have a high ACA ratio or reduced accommodative facility or high accommodation lag. Now, accommodation lag is a lot more difficult to measure in a clinical setting because you need a way of measuring the refraction accurately when you're holding a target close by. So that's something that most clinicians won't be able to do. But the other 4 most clinicians should be able to do fairly easily in a clinical setting to find out whether they have a family history, how much prescription they have, what their ACA ratio or accommodative facility is like. Okay. So what do you do as a lifestyle management? There are two things that we need to do. One is focused on near work, the other is outdoor. So when they're doing near work, we have to recommend regular breaks and fixation changes from near to distance. What I tend to recommend is 20-20-20 rule because it's easy for patients to remember. Okay. Every 20 minutes, take a break for 20 seconds and look at something at least 20 feet away. Okay. So every 20 minutes, that break will relax their accommodation. 20 seconds is a very reasonable amount of time because accommodation tends to work within milliseconds. So 20 seconds of looking at distance is going to wash out that effect of 20 minutes of reading that they did. Okay, so they're not having, if somebody is working on a computer, they don't have to get up and walk around or anything. This is very, very easy to do. Okay. The other thing is appropriate reading distance. We very often see children who will hold their phones or books somewhere very, very close to their eye to read. Okay. Now, reminding them that appropriate reading distance is important is also a helpful thing to do. Okay. Coming to time outdoors, every hour of time spent outdoors per week reduces the risk of myopia development by 2%. Okay. And that is a big protective effect. So this is per week, an hour, which is reducing the risk by 2%. So overall, what we tend to recommend is ideally 14 hours of outdoor activity per week, which will be 2 hours a day. Okay. Minimum tends to be 8 to 15 hours. They can, of course, do more. This is the minimum, not the maximum. But my suggestion to patients tends to be at least a couple of hours a day. Spend time outdoors, walking, playing, whatever for the kids, and that will protect them against developing myopia. Now, maximize indoor lighting where you can and use warm white rather than fluorescent lighting. So fluorescent lighting has a lot of blue wavelengths in it, whereas warm white will have less of the blue and have more of a yellow light, which also has a protective effect when compared to the blue wavelengths. Now, TV screens are another major issue. You'll see children going and sitting very close to the TV screen to watch it, which again doesn't quite help. So the ideal distance is at least 3 meters or more for the TV screen. So these are the lifestyle intervention advice that you can give your patients, and they should be helpful, particularly for those who haven't developed myopia yet. Okay, if they do develop myopia, these are helpful, but not as much as those who haven't developed it yet. Moving on to optical interventions. Spectacle lenses that we all prescribe are very important. And what we know is even if you're not doing any specialist myopia control lenses for the patient, do an up-to-date full correction. There is enough evidence that undercorrecting myopes promotes myopia progression. Okay. We are often, when we were at university, are told, stop the patient from accommodating, give them maximum plus. And in that endeavor, a lot of the times people used to give too much plus to the myopes and they'll be undercorrected by even up to 0.75 diopters. Okay. And that we know is not a helpful thing to do anymore. We don't want to overcorrect for sure. Yes, accommodation has a big impact on comfort, eye strain, and so on. So up-to-date full correction is important here. Okay. Now, bifocals or progressive lenses for myopia were tried and are still sometimes used, but these have now been pretty much superseded by the specialist myopia control lenses. These lead to small but clinically insignificant reduction in myopia. Okay, but they have been successful on patients who have esophoria. Again, when you use the myopia control spectacles designed for that purpose, that effect tends to be much higher in all these patients. So moving on to myopia management spectacal lenses, there are a lot of designs available now. These are the three most commonly used ones: MyoSmart, MyoCare, and Stellest. So MyoSmart is the one that I've shown at the top picture there with a honeycomb shape of lenslets. I've taken this image in lighting, which is going to make those lenslet apparent, but actually when you see the spectacles, you don't see that honeycomb pattern at all. It's very, very difficult to take this picture rather than this being visible in every picture. You don't even see that these are any different to normal lenses usually. And the picture below that is from interferometry, where we show each of these lenslet and what effect it has on the light rays. And each of these lenslets add a plus 3.5 diopter power in the periphery. So we talked about the peripheral refraction before, on how the periphery is a lot more hyperopic than the center. So that plus 3.5 diopter of correction in those little lenslets, which are called multiple segments. So they are defocus incorporated multiple segment lenses, all of these. And these multiple segments with that plus 3 diopter power correct for that peripheral hyperopia and stop the signal for the eye to grow longer to correct the error in the periphery. So that's what these are doing. The Stellest lenses have a similar design, but instead of that honeycomb pattern, they tend to go in circles, but they have these segments which are circular, and instead of having the plus 3.5 diopter spherical power, they tend to have a more progressive aspheric power within those lenslets or the segments. Okay. The MyoCare design tends to be slightly different. You have a MyoCare lens example here where you can see the care, unless these are cylindrical annuli here, which again add a plus power, but in cylindrical fashion here. And they are shown to reduce myopia progression too by exactly the same thing. They're correcting the peripheral hyperopia with these cylindrical annuli. So they're circular but cylindrical in this case. Now, MyoCare has MyoCare lenses are prescribed for younger children, but for teenagers, it becomes MyoCare S. And all these lenses have shown varying levels of myopia protection effect, as it were. MyoSmart claimed to have 60% efficiency in reducing myopia progression. I'll come to these efficiency figures later, but the use of percentages for measuring efficiency is highly disputed now because it all depends on how much the other group progressed. And now with myopia control pretty much becoming the norm, it's very, very difficult to recruit patients who are true controls, who've not taken part in any other myopia control initiative or lifestyle changes, etc. So that's a more disputed figure right now using percentages. Now, optical interventions will also include contact lenses and orthokeratology. Orthokeratology reshapes the cornea, as you all already know, I'm sure. Contact lenses are worn overnight, and this alters their corneal shape so that the peripheral refractive error is also changed. And as a result, the need for accommodation also changes after orthokeratology when they are walking around during the day with that new corneal shape that they gain through orthokeratology. And this tends to control myopia progression by about 40%. Okay. Contact lenses, again, standard soft contact lenses do not affect myopia progression at all. RGPs have a moderate effect, but that's due to the corneal flattening, very similar to what we see in orthokeratology. But there are multiple multifocal contact lens designs that reduce peripheral hyperopia and reduce accommodative lag and have shown to reduce myopia progression. One example is this Myosight lens. And as you can see here, this study reported the reduction in diopters per year in the first 2 years. So they showed a reduction in 0.27 to 0.66 diopter per year in the first 2 years. But other than Myosight, there's also Biofinity and other extended depth of focus designs, which are all licensed for myopia control. Atropine is another thing which is getting more and more popular for myopia control, given that we're not using a full 1% atropine for myopia control anymore. The myopia control dose for atropine, which is now approved for use in UK and most European countries, is 0.01%, which is a very, very low dose of atropine and doesn't affect accommodation as much. These doses of atropine have a much lower effect of controlling myopia than the higher doses, but nonetheless, they're still useful and they're not causing the high side effects that a full 1% atropine did, and hence this is becoming more popular now. So atropine works by thickening the scleral tissue and reducing the elasticity of the eye to elongate, okay? And as a result, if the eye isn't malleable enough to elongate, it's going to not progress as highly as an eye which doesn't have that protection. So it's highly effective in reducing myopia progression. Low-dose atropines had a similar control effect without that impact on accommodation. Can everybody see my slides again?
Yes, ma'am.
Yeah.
We can, it is visible, ma'am.
Okay, that's great. Thank you. So atropine, particularly the high doses, had a big rebound effect. That's much, much lower with the low doses. But again, with atropine, the chance of rebound is there. So once you start somebody on low dose atropine treatment, the recommendation is that they continue using atropine to age 18 or 21 to ensure that they don't develop the rebound effect, because by then rebound doesn't happen. Now, a new treatment that is becoming popular in some parts of the world is this repeated low-level red light therapy. This uses semiconductor laser of about 650 nanometer, which is visible red light. And these work by increasing choroidal blood flow and introducing choroidal thickening. Now, I would use a bit of caution with this treatment. The only papers on this have come from Chinese regions. The paper which assessed this technology in the US actually found the laser light that is coming out of these devices to be too high in intensity, so it wasn't deemed safe for use in the eye. So we don't, I've looked through these and they are really, really bright red lights. So we'll have to be a little more cautious in adopting anything like this and making sure that the amount of red light that's being used is actually safe for the eye and might control the length of the eye, but we don't want anything to cause long-term damage to the retina by use of really high intensity lasers. So unless that safety profile is better or that safety profile is clearly known and modifiable intensity of the laser, I'll be reluctant to use anything like this with anyone. So moving on to efficacy that I was talking about before. Now, we do talk about the efficacy of different myopia control treatments. And this is a study that we did a couple of years ago on trying to see how efficacy changes over time. And we've done this in time per month and 6 months efficacy in axial length control and spherical equivalent control. And as you can see, the efficacy of any treatment, whether Stellest or Myosmart, actually keeps going down over time. What starts off as 60 to 70% efficacy in the first 6 months can go down to 50 to 40% efficacy in the last 6 months of this 2-year period. So efficacy does decrease over time, and that's often because the eye adapts. And that adaptation is important to consider, that what you had initially will change over time. But in addition to the eye adapting, the eye is also going to slow down in growth. As we get older, we don't actually, the eye growth is not as high. So that natural reduction in progression will also happen. Okay. So efficacy over 3 years, and almost every study shows that the efficacy reduces after the first year, only exception being red light therapy. But this information comes from a limited set of papers from a couple of groups, and we need more evidence before we start believing this from more independent assessment of the treatment. So until then, judgment is reserved for this, but for all the other treatment modalities here, there is a reduction in efficacy over time. First year tends to be the year which has the best results in terms of myopia control effects. And some of these treatments, such as atropine, will have a rebound effect. Okay. So the other thing that we need to think about is combination therapy. The most common combination therapy we tend to use is lifestyle and optical. Very often, we would prescribe somebody a spectacle lens or a contact lens for myopia control, but also give them lifestyle advice. And that combination therapy works brilliantly, doesn't have any kind of negative effects. So that's always good to do. But evidence is now coming for more and more combined optical and pharmacological interventions, particularly use of atropine alongside spectacle or contact lens-based myopia control treatments. And it works sometimes with non-responders, with those who didn't respond to just one of these treatments. Adding two seems to help. Some more results now coming out with red light therapy as a combination therapy with other modalities too. But again, we'll have to wait for more evidence for that to come through to be considered on the mainstream. So what does this all mean? And what shall I tell my patients? I have talked a lot about everything, so I'm trying to summarize this as best as I can. First is always myopia prevention, particularly for those who are at high risk of developing myopia. Recommend increased outdoor activity of at least 10 to 14 hours per week. Myopia control, lots of different options are available, and they're all targeting both accommodative lag and peripheral refraction. And with that, I also want to highlight that there's still a lot of unknowns. Okay, there's role of melatonin in circadian rhythm. There's some evidence that kids who don't sleep enough are more likely to develop myopia than those who do. And there are all these weird and wonderful treatments about posture and working distance that are being tried in different parts of the world. So these could all have an impact, and there is a lot more that is under the surface. So we're probably still working at a level where we don't know all the factors that are involved. but there's always guidance out there. The International Myopia Institute is a great place to go for information. UK has a College of Optometrists myopia guidance, and I've highlighted the European guidance here, of which I am an author as well. So there are lots of myopia guidance papers available on how to manage patients with myopia if you need more information. And I would like to thank all my collaborators that have enabled all the work that I presented today to be possible. Without the help and support of some senior staff and the hard work of some of my PhD students and postdoc, none of this would have ever been possible. And thank you very much for listening.
Thank you so much, ma'am, for the wonderful and inspiring session. It was truly insightful.
Thank you, my pleasure.
So anybody
Hema,
have
hi.
questions?
Thank you so much. It's like I had a complete revision of myopia management, and the whole theories behind it. It was absolutely brilliant listening to it again. Just a quick question. Now, what happens when it is a pre-myope? Do we start them on some sort of a myopia control, say spectacle lens or atropine? Because there's a big controversy going on here right now. So I'm not sure what to do with pre-myope. So say a 7-year-old who's a plano or a plus 0.25 or a plus 0.25, say, what do you do then?
Yeah. Personally, I would never go for atropine on a pre-myope. I know that is prescribed by quite a few people, but atropine has a rebound effect. However low the dose, and we'll have to keep going on for a very long time with atropine to make sure that they don't get that rebound effect. Spectacle lenses are not a bad idea if the patient is keen to have it rather than the patient, it's the parents, because the parents are the ones who would have myopia and they really don't want their kid to get to that stage. So I would recommend perhaps spectacles and lifestyle changes, but often it's also good enough to monitor them for 6 months or so and see how their prescription is changing with just the lifestyle. And if they do come to zero, then at that point I would start prescribing, not before.
Right. So there's yet another question. We've had a few anisometropic myopes, some who have myopia in one eye and some who are almost plano in the other eye, or some who are antimetropes, plus and minus, one in each eye. We've noticed that the plano or the hyperopic eye seems to be progressing in axial elongation seems to be much higher. Have you noticed anything like that? And if so, any idea why that happens?
I think the axial elongation very often tends to be bilateral. So it might be that whatever impact the lifestyle choices or parental genetic impact is accelerated in that eye, but there isn't enough evidence at all, Saranya, on these anisometropic myopes to form any conclusive things, because all the clinical trials, all the research has been done just on myopes and emmetropes. You're talking about the group which is always excluded. So maybe if you want, we can talk about it offline and try and see what we can do with it.
Yeah, I think we should. So, I mean, I probably sort of threw your year off with more questions. So I'm just going to leave the forum open for others to ask you the questions as well.
Sure, but happy to talk later.
Yeah, pleasure. Shamla, are there any questions from the group?
I would like to ask the
Yeah, thank you.
questions which is asked by the attendees to a Google form. So the first question is, what criteria are considered to stop myopia control?
Uh, that's not there isn't 100% agreed thing about stopping myopia control. Right now, we know that for atropine, the criteria is age. You keep going on until they're old enough to not have a rebound effect. But for other treatments, you stop when the progression has pretty much come to a plateau. So you're sure that stopping this won't let them progress further. What people have done is try to stop the treatment, see how the eye has progressed. If the progression increase, then they put them back on the treatment. And that's been the common strategy rather than just suddenly deciding to stop and thinking it'll all be okay, because we don't know how each eye will behave.
Okay. The second question is disadvantages of AI in myopic progression. What you feel?
What do you mean by disadvantages of AI? I think their AI hasn't really been integrated enough into myopia treatment as such, but there
No, I
is.
think, Hema, they're asking about possible effect of people using so much of AI for everything. Are you in a network
Yeah,
question?
there is no evidence for using even a computer device versus a book causes any difference in myopia. So whether you use AI or internet or
Network question.
play a Minecraft game makes no difference. It's just the fact that you're looking at near, which makes a bigger impact.
It's connected.
There's a question here how dopamine plays a role in myopia control. So dopamine and GABA, sorry? Yeah. Dopamine and GABA have a link that if dopamine is high, it has a protective effect from the eye growing longer. So they work at a cellular level. And GABA makes the eye grow longer. So we did a study which was published last year on gut microbiome and its impact on myopia. So when we analyze the gut microbiome differences between myopes and emmetropes, we found that the bacteria in the gut, which produce more GABA, were higher in progressing myopes. So those who progress more had these GABA producing bacteria, whereas those who were emmetropes or not progressing had more dominance of dopamine producing bacteria.
The next question is from Davamadi ma'am. How accurate are current myopia risk calculator in predicting future axial elongation or refractive error?
Uh, Reasonably so. It depends on which one you're using, but they keep evolving with all the new data that keeps coming up. So they are reasonably good in calculating it, but it is very much an average, right? So you could take the average growth charts of a child and say, if you're this tall, you will get to this height in the next 2 years based on that growth chart. But that is from the average data in the population. Similarly, this is also from average data in that population. And this child might deviate somehow from that slightly, but the trends tend to be similar.
So I would like to thank ma'am for spending a valuable time with us today and sharing such meaningful insight. If you wish to view the earlier episodes of Acchutha Inspired series, they are available on the Acchutha Institute of Optometry official YouTube channel. You are kindly encouraged to subscribe to the channel for future updates. Before we wrap up, thank you. Before we wrap up, I have shared today's quiz link in the chat box. Please fill it out to receive your OCA certificate. with 2 credit points, co-signed by Acchutha and OCA. Once again, thank you, ma'am, and thanks to everyone here for joining and making this session a success.
Thanks, Shamla, and thanks everybody for organizing this. Bye.